Welcome everyone to this IIRSI Intraocular Implant and Refractive Society of India initiative of organizing the series of webinars. Well, these series of webinars have been dissecting situations, and the instruction course webinars, which we have already organized, include one on zonulopathy, the second on vitrectomy for anterior segment surgeons, which can be logged on YouTube for reference. Well, all this is basically nothing but a brainchild of our president, Dr. Himanshu Mehta, who coincidentally is the moderator. I take this opportunity to thank Dr. Amar Agarwal, Dr. Mahipal Sachdev, Dr. Mohan Rajan, and our dear friend Dr. Gaurav Luthra for this opportunity of organizing this third series of instruction course webinar. Well, the topic of the day is Unaided 2020 Cataract Refractive Surgery, a reality check. Well, the question is, we started with IOLs without biometry. And I remember those days in India in early 80s when we used to do IOLs without biometry. And when we had a biometer, every person used to throng and see it. And we have reached a stage where we have artificial intelligence-based calculators. Patients' expectations have also hit the roof. But still, there are gray areas. Emetopia is not 6 by 6 as we have in LASIK, in refractive surgery. Well, in cataract refractive, it is hitting within plus minus 0.50 diopters. Well, around 9% of people have off target of this plus and minus 0.50 diopters. Another gray area is post-refractive surgery biometry. So there are borderline astigmatism we are not sure, which is another challenge. Today, to unfold all this, we have a galaxy of speakers from across the earth, who will unfold the present and future of 2020 unaided. I request Dr. Himanshu to take over and introduce everybody so that we can take on and move on to this interesting webinar. Over to Himanshu, please.
Thank you, Dr. Rohit. Thank you very much for a lovely introduction. Friends, IIRSI always has moved from one place to another place, and we are quite international right now. We have had so many good conferences, and the real aim for every anterior segment surgeon, who is majority of the time a cataract surgeon, is to give the best possible vision, from extracapsular surgery, from intracapsular to extracapsular to in the bag, out of the bag, IOL. We have moved places. From the machines, from the femtolaser, from the phacoemulsification to the femtolaser, and all your lens implant, from the silicone implant, the glass implant to our hydrophobic acrylic, and now we have such wonderful multifocals also. But the enigma always has been the beautiful structure called eye, and the algorithms and your formulae to calculate the exact IOL power. The regular ones do well, but what about out of the range? The out of the box people, less than 22 millimeters and more than 28 millimeters extra length. What do we do in such cases? Where are we going wrong? Because now, we have promised patients the sky. We told them no stitch, no pain. We're not even going to put a tape on your eye. You'll be out in 10 minutes and you will see the whole world. The expectations given is huge, and the patient's expectation has gone up huge. And we have tried to meet up with the expectation as a surgeon. A surgeon is pressed big time between the patients, the equipment manufacturer, and the lens. So despite him being a great surgeon, he may not be able to deliver the best possible stuff, because unfortunately, there was something wrong with the formula calculation and or whatever that you use, your constant. To reduce all those problems, to have consistency in our approach, we have learned and we have evolved over the past. We have evolved with great people in this world who have made this so possible. Dr. Douglas Koch, Dr. Warren Hill are pioneers in the field, and it's a great pleasure to have them here this evening to talk to us and teach us exactly how can we make perfect the 2020 goal. Every day we are perfecting our own formulae, our own methodology, our technology to see that patients get the best. Our first speaker is Dr. Douglas Koch, and it gives me a great pleasure and honor. It was about 30 years back when I walked into his consulting to say that I want to see a few cases and work with you for some time. And I was an observer with him about 91. And from that time, he was such an impressive figure. And I followed him all across. I've stalked him all along. And it's been a pleasure to see him in all the meetings internationally and nationally. Dr. Koch is a professor and the Allen Mosbacca, and the law chair in ophthalmology at the Cullen Eye Institute, Department of Ophthalmology, Baylor College of Medicine. He is the editor emeritus of the Journal of Cataract and Refractive Surgery and the past president of the American Society of Cataract and Refractive Surgery, the American Ophthalmological Society, and the International Intraocular Implant Club. He's authored over 200 articles and book chapters on the topics of cataract and refractive surgery. I know I want to make it short, but as short as I can make it, the least I can say is he's got 30 named lectures, including the Jackson Memorial, Kelman, Bing Cause Barracuda lectures at the American Academy of Ophthalmology, Charles Kelman Innovator Award lecture in 2012 in the annual meeting, and the whole thing goes on and on. He had received in 2013 the Leslie Dana Gold Medal from the St. Louis Society for the Blind and Visually Impaired. He has been a wonderful teacher, a great person all along, and a great human, as Warren Hill also mentioned at the beginning. Over to you, Dr. Koch, for your presentation. Thanks so much for being with us.
Thank you, Dr. Manchu. What a pleasure it is to be here. Let me share my screen. And I'm always so pleased to share the podium with Warren Hill, whose work has been so important in all the things that I've been doing and who I respect so much. So let's just bring this up and bring up the slideshow here. The title of my talk is IOL Calculations 2021 Progress and Limits. Let me just reduce that. There we go. Most of us need to do better. That's the first message. And actually, Dr. Hill has taught us that as well. Let's see. Okay. How well do we do in clinical practice? In the literature, what you find by and large is that we hit about 70 to 80% with a half diopter predicted. The largest study that I know of was from Mellis in ophthalmology in 2018, and they were just at 80% with a half diopter, and that's with relatively normal eyes. We do worse with complex eyes. The best data that I've seen are actually being published by Adi Abalafia and his group from Israel with 153 eyes, most with normal axial length. And guess what formula they used? The Hill RBF3, the Barrett Universal 2, and the EVO, and they had over 92% with a half diopter target. Slightly best, I might point out, with the Hill RBF3. But I think this is probably the best that we can expect to achieve with our IOL calculations, and I'll go into that a little bit. What do we measure when we do calcs? We measure the anterior cornea, the axial length, anterior chamber depth, lens thickness, corneal diameter. We may measure posterior corneal curvature. We may measure corneal thickness. Other people will add in the refraction, perhaps the patient age, gender, and ethnicities. There are a lot of factors that come into IOL calculation formulas today. And what are the sources of error? Well, Norby in his 2008 classic paper said it was the ELP, axial length, and refraction that give us these errors. But what about today? Well, ELP is still there, but the cornea now has become a major contributor or problem for our measurements in terms of getting that last level of accuracy, and refraction remains an important source as well. So why is axial length no longer on the list? Well, of course, it's because of optical biometry and its extraordinary accuracy. How do we calculate IOL power? Well, the classic formulas are variants of the Virgin's formula, where we insert the post-op refraction, we insert the K readings, the axial length, and then each formula internally has an internal formula to calculate the effective lens position, all of which then gives you the predicted IOL power. Well, things are really, as was pointed out, really different today. We have formulas that are based on geometric optics, and they vary according to the number of variables, whether to calculate the effective lens position, whether it's 2, whether it's 5 in the case of the Barrett, 7 in the case of Holiday 2, or in the case of the Panacea, they actually add in the ratio of the posterior to the anterior corneal radius of curvature and the corneal Q value. Then we have ray tracing, the Oculix formula, but more commonly used, the Olsen. And then, of course, artificial intelligence, Hill RBF now, as you'll hear today, the 3, Pearl, and Clark. And then we have combination formulas that take some geometric optics and they add a whole lot of artificial intelligence in them. And in fact, a lot of the artificial intelligence formulas, such as the Barrett and others, actually also have a little element. I mean, the Virgin's formulas have a little element of artificial intelligence. So it's interesting how things are converging in some respects, although we do have just elegant, pure artificial intelligence formulas. So what's ideally the best? Well, theoretically, I would think that ray tracing would be the best because it incorporates all the aberrations in the calculation, the cornea, the IOL, the asphericities, et cetera. And we've done studies looking at what would happen if you segment the axial length, because each region of the eye has a unique index of refraction, aqueous, lens, vitreous, and you can get a customized measurement of each patient's axial length. And what we found using the Barrett Universal 2 was that there was some benefit, but really only for axial lengths that were at the extremes. So Dr. Barrett has already kind of factored some of this stuff into his formula, interestingly enough. But the limitation of ray tracing, as with all formulas, is solving the problem of predicting the effective lens position. So the outcomes with ray tracing formulas to date are no better than our other best formulas. And maybe the current role for ray tracing might be in eyes with irregular corneas so that it can factor in all those asymmetries in the corneal topography. So can we improve the prediction of effective lens position? Well, there have been a lot of studies looking at that using OCT preoperatively and intraoperatively. I've listed the references, and they did show improved prediction of ELP, but none of them showed superior IOL calculation accuracy, interestingly enough. And the thing that makes it a very great challenge for us is that depending on the lens, but the effective lens position shifts postoperatively, and it's not predictable. A study by Hernshaw and Oliver Findle showed that the 17% of eyes had an anterior chamber shift of greater than 1 millimeter from 1 hour to 2 months postoperatively. And how many of us have seen patients who come in 1 day postoperatively in their 20/20, they come back at 3 weeks in their 20/25 or 20/30 because of the change in the effective lens position. Short eyes are, I think, among our most challenging. In our study of many formulas, including the Barrett and the Hill RBF 2, not 3, we found that the Holiday formula, and particularly the Holiday 2, did best, still under 80% within a half diopter. And these were not the extremes of short eyes, just mostly 20.5 to 22 millimeters in length. And other studies subsequently have had basically the same results. So I'll be interested to hear what Warren has to share with his new RBF3. And the reason for the poor outcome is the difficulty with effective lens position. You have a high-powered IOL. A small shift in its position induces a big refractive change. And the other thing is when you do adjustments, we normally would do a half adjustment when we go from one eye to the next. If you're off by a diopter in the first eye, you make a half diopter adjustment in the second eye. But in these eyes, that 50% rule may not work. These eyes may be so unique that you may need to make a bigger adjustment. Interesting eyes to challenge. We're doing better with long eyes. The best formulas, well, we first proposed the Wang-Koch modification, and here's the formula. When we got a data set from Warren Hill, we got 93% within a half diopter for eyes of 26.5 millimeter and longer. But fortunately, we now have a lot of superb options. We look at the Hill RBF3 very closely because it's actually remarkably close to what we get. Barrett Universal is great, Kane and Olson. So I think there are lots of good choices now for our colleagues for the long eyes, and we're doing really, I think, very well. And the reason is the power of the IOL is low, so that small differences in the effective lens position have a minimal impact on the refractive outcome. What about the post-LASIK eye? Well, I think we're still not doing very well. The best study I saw was one that had 85% within a half diopter by Nicole Fram and Sam Maskett. But that's really an isolated study. Almost all the other studies I've seen are under 80%, and many are under 73%. Here's a study with the Barrett True-K, 73.4%. Our results for the Barrett True-K in one study, 57%. What about the fact that we can now measure posterior corneal power? Unfortunately, that's not provided the benefit we had hoped for yet. The IOL master with total keratometry, Graham Barrett reported his formula with that, 72% within a half diopter. Still a bit disappointing. We found we could use the standard Hygus formula with total keratometry, but we were still, for myopic, hyperopic LASIK and RK eyes, under 70% within a half diopter. What about aura? Well, It does take into account the posterior cornea, but our data show that it's slightly worse than our preoperative calculations for LASIK eyes, although we do measure with several devices, including the Avanti OCT, which is one of our more accurate approaches. One valuable role for aberrometry is error prevention. Here's an eye and a patient of mine where the IIRSI calculator predicted 23.0 or recommended 24.5, and we were puzzled. We looked back, and an incorrect value for axial length was inserted into the ASCRS website by my fellow. So this is one of the things I'm going to focus on as a conclusion, and that is error prevention. And the problem with intraoperative aberrometry is that it's using its internal IOL calculation formulas on an altered eye, and it's still trying to predict the effective lens position. Keratoconus is an even bigger challenge. The steeper the cornea, the greater the hyperopic error. These are data that Sumitra Khandelwal compiled from our data and from the sites you see listed below. We do pretty well up to about a 50 diopter cornea, but beyond that, the scatter in the data is huge with a very low R-squared for prediction in this group. I'll be interested to see how the new keratoconus formulas from Kane and Barrett work. I think that's a promising approach. Well, that brings us back to what we can control today in our practices, other than using the best formulas. Here's a patient who came to me for IOL calculations. The measurement was 43.34 with a lens star, 2 diopters of astigmatism. So I'm starting to think about, let's do a toric IOL. But the IOL master the same day gave no K readings. And if you look at the IOL master, you can see that there's a missing LED reflection. So the IOL master said something's wrong and wouldn't even give me a K reading. So it turns out this patient had seen me 3 months before, and we'd gotten a Galilei, and the SIM-K from the Galilei was 44.6, as opposed to the 43.34 we got with a lens star on the pre-op day. And the astigmatism previously was 0.1 as opposed to 2.05. So we looked at the LED Myers from the lens star, and you can see that consistently in the same area that the IOL master was missing data, you can see the irregular data points that caused an inaccurate reading from the lens star. We treated the surface. Now you can see the Myers look good, and the calculation turned out great, 20/20 J2 with a spherical, not a toric, EDOF. So corneal power is a major source of error, and we need more than one measurement, and you have to validate the quality of your raw data. Here's another example, an eye who length 27 and one eye 26.59. You get warning signals when there's that big a difference between eyes. But look at the standard deviation here of the axial length, 0.127, whereas our criteria for Morin actually is has to be greater than less than 0.02, and this is much greater than that. And you can see all these measurements with that high standard deviation. The IOL master the same day, 26.93, which is very similar to the fellow eye of 27.03, not identical, but fairly close. So we repeated the measurement with a lens star, and we got similar readings. And the problem was the optical head was too close to the eye, just another way you can induce error. And we have validation criteria, and again, Warren has talked about this, and we have this editorial published on that. And these are listed here if anybody wants to take a snapshot of the screen, but that's what we use. Confirm the measurement mode, difference between the eyes of axial length no more than 0.2, where we have to double check the standard deviation less than 0.02, and you can see the parameters for phakic anterior chamber depth and lens thickness. So what about postoperative modification of IOL power? Well, is it going to be the go-to for all of our eyes, or is it only going to be for outlier eyes, which I suspect it will be because we're doing so much better with our formulas. And there are these technologies, IIRSI and Perfect Lens Clario. We'll see how they fit into practice. They're complicated, they're expensive, but they are promising certainly for the more difficult eyes. One final word, it's time to change our statistics. We published a paper showing a new approach that says that the standard deviation is the single best parameter to characterize the performance of IOL calculation formulas in the January JCRS. And we are finding that that's superior to mean absolute and median absolute errors. So it's going to be a new way we'll be thinking about our formulas. And with that, thank you very much for your attention.
Thank you so much for a wonderful presentation, Dr. Koch. Brilliant. We have Dr. Ramamurthy also with us and Gaurav. So now that we have at the posterior cornea, how much does the posterior cornea also matter? You wrote so much about it, and you just have made everybody aware of the significance of posterior cornea over a period of time. What is the
Well,
main? Yes, sorry.
For toric IOL calculations is huge. I mean, everybody around the world now is using it in their toric IOL calculations. But for standard IOL calculations, we use a Gulf-Strand ratio to the front of the back, and we just use the anterior corneal power. And for the vast majority of eyes, that seems to work well. But there are outlier eyes where the ratio to the front of the back, even in normal patients, is not the same. But I will say we've looked at data with the IOLMaster 700 and seen studies where total keratometry actually isn't really giving any particular advantage to just doing the anterior cornea. I think for post-LASIK eyes, it's going to make us a little bit better, but there are so many other sources of error, it's hard for that one little factor to make that big a difference. I'd be interested in what Warren thinks about that as well.
At this point in time, the effective lens positioning is one of the biggest criteria that's changing our the answers, the post-operative refractive answer. Is that correct? Absolutely.
And so in most of the geometric optics formulas, they all try to predict the effective lens position. The artificial intelligence formulas say we're not going to try to calculate an effective lens position. We're just going to try to match the IOL to the anatomical features of that eye, which is a very interesting approach. But a lot of the formulas are doing a little geometric optics, and they're throwing in some artificial intelligence because the geometric optics aren't accurate enough. And every one of them, the Barrett and others, have artificial intelligence, which means they've looked at past data and they've modified the geometric optics based on those past data for certain types of eyes.
How much would be the kind of lens which you're using, a multifocal lens, a trifocal lens, and the newer lenses which you've come up, the EDOF and all that? How much would that matter with respect to the calculation? Would the lens also matter in our results?
Well, I mean, we certainly, for certain lenses, and the EDOF lenses, you probably have a little more range. You can get a good result because they have a flatter landing zone, as it were. But the trifocal, we find with the PanOptix trifocal, for example, and with the J&J multifocal lenses that we have in the US, we don't have all the lenses you have in India. You have to be really right on target because there's a very small landing zone. And if you're off in your calculations, the patient will be myopic or hyperopic and not get the true benefit, or at least the full benefit of that lens.
A PanOptix, we would go on absolute 0-0, or would you go a little myopic?
I am on the first minus. And I do that because if I have to enhance them later, I'd rather enhance with a simple myopic LASIK or PRK than rather having to do a hyperopic procedure. So that's what we do with a PanOptix. And we use for those, by the way, our go-to formulas are the Hill RBF3 and the Barrett Universal 2. We also look at the Holiday 2 as well from the IOLMaster 700.
As of today, if I was to say the outlier on the upper side, for the myopic eyes, you said we are fairly decent, we are moving better. But on the hypermetropic side, an 18 or a 16 millimeter length eyeball, we have problems there still.
Yeah, those are really a challenge. They're part of the challenge with them. You've got to have a great surgery and make sure that you don't create a situation where there is an anterior shift of the IOL that's permanent from anatomical reasons. But we've actually found in the few eyes that we've done that the Holiday 2 is the best formula for us in those eyes. It seems to be, we've done probably a series of 7 or 8 or 9 of them lately in the last few years. And the Holiday 2 seemed to be the best one that worked for us. I don't know. I'd be interested to hear others' experience in that regard because I don't have a large number of them.
I just did a plus 56 diopter lens, and I was perplexed tremendously as to what to be used. But Hoffer Q came a little closer post-operatively that I could think of. Something.
Oh, that's great.
Himanshu, can I ask a question? It was really a wonderful opening lecture from your side, Dr. Koch. I just want to have opinion on, we used to talk a lot about a constant of a particular IOL design material-wise. What is your point of view in a current scenario? Is there a requirement for personalized A constant now to get a better outcome?
I think that if you're doing standard clear corneal, small incision cataract surgery, the A constant that you get from a large group of data is probably absolutely adequate. I think that any changes in the A constant that a surgeon will do, I would think by and large may relate to the length of the lane in which they're refracting the patient. So if you have a short lane, you're gonna refract the patient to a more myopic, a stronger A constant because you need a little bit stronger IOL. But if you extrapolate that to 6 meters or infinity, then the A constants should be. I think they're really, since we're all doing roughly the same surgery, I think personalizing the A constants doesn't really make sense anymore.
Okay.
Great presentation, Dr. Dog. I have a question for you. No, I keep hearing this Ramamurthy here. I keep hearing this, use multiple formulae, use multiple instruments and verify. But sometimes that leads to confusion, as to which one is giving you the right reading. So for a busy practice, most often you would like to, especially for the normal run-of-the-mill eyes, you would like to take measurement from one instrument, use one formula and plug it in. And I know that, there is a suggestion that you take from 3 different instruments and use the median, but I'm not really convinced by that. Your recommendation?
I think everybody should at least get 2 measurements. You can do it one of 2 ways. You can get 2 different instruments on the same day, or use the same instrument and get it on 2 different days. So, but you need a second. That case that I just showed you, the patient with the abnormal lens star readings shows you that we can have tremendous errors if we only rely on one measurement. Of course, I could have validated. There are ways I could have figured that out simply by looking at standard deviations and so on. But I think we all need to get 2 measurements if we want to be as accurate as we can. Regarding formulas, the best that we have, Hill RBF3, Barrett, Evo, those formulas are fantastic. Do we need to look at all 3 of them? I'm not sure that we do. I like to at least look at 2 different ones because if there's a difference, I might shift in one direction or the other. But I don't think we need to take 10 measurements, and I don't think we need to have 10 machines. But I think if you have a really good machine, you measure 2 different times, or ideally, 1 measurement is the biometer and 1 measurement is topography. And topography in contemporary practice should be really a part of almost every practice, I think.
Dr. Titial, I would like to ask you one question.
Yeah.
Which biometer are you using, and what is your preferred one? That is the first part of the question. And under what conditions, because you have an array of biometers with you, the lens star, which has a Hill RBF, and optical biometry with IOL Master. What is your mode? What are the situations in which you use different and what is the preferred one?
Thank you, Rohit. Currently, we are all shifted to optical biometry. And most often we use IOL Master 700 nowadays. And that has become the standard. And you know that in our scenario, we do get patients where sometimes optical biometry may not be sufficient enough to get a good axial length. Though as Dr. Koch rightly said, we do use corneal parameters from IOL Master 700. But in those cases, where we can't get the axial length, we like to do immersion biometry for these cases. And that will be required around 15 to 20% of all cases. Otherwise, cases where we do have poor keratometry reading coming from IOL Master 700, then in those cases, we like to do a pentacam to see that corneal topography. But most often, we would be all right with optical biometers. And that should be the standard as such.
Ramamurthy, would you like to add something?
We are also shifted almost completely to optical biometry. And we have IOL Master 700, IOL Master 500, the lens star, and the Tommy biometers also. I feel that in most cases, they are all quite reliable and trustworthy. And only our approach to these patients itself has changed, in the sense the first thing that we do with these patients before even counseling, once the patient is, uh, uh, we know that the patient is in for cataract surgery, the first thing we do is biometry. And what we are looking at is keratometry values. Because based on that, our entire counseling for monofocals or toric or multifocals or multifocal toric changes. Because as you all know that even a 0.75 or a diopters of astigmatism, especially against the rule, has a great impact on multifocals. Earlier, we used to see that we had counseled the patient for multifocals and has hardly been wearing any astigmatic glasses. But then once you do the biometry, you find that there is significant corneal astigmatism, your whole approach changes. I believe that investment on a good optical biometry is something every cataract surgeon should do, and it's something that significantly enhances. The good thing is that many of these instruments today come with this formulae built in, and in case you are using an immersion A scan, still you can go to the ACRS, APSCRS websites and have the benefit of these formulae. But then that's a lot of work, and having it all put together in one instrument is a good advantage.
Dr. Koch, each machine has a mind of its own, and each one of them give you a different calorimetry reading. Now you said you can also rely on topography. Would you rely on the keratometry reading of a topography or only the axis? Would you rely on kerato, because that makes a huge difference in the whole calculation? Which machine would you rely on?
I rely on for corneal power. I rely on the biometer. I like to look at the topography to look at regularity of the astigmatism, and particularly to kind of figure out the meridian of the astigmatism. But I also like topography. I like placido topography because I like to look at the mires on the cornea, because that also gives me a sense of the surface quality and I can detect some dry eye. So, but for power, the biometer. And also for the magnitude of astigmatism, I rely more on the biometer than the topographer.
You showed the Varion aura. Would you rely on Varion? Because I see, again, each machine has such a different mind of its own. And
I don't have any experience with it. We had it at our VA hospital, and it's sitting in the corner.
There was a study by
very interesting, because the garbage in, garbage out giga, if our keratometry reading is wrong, the biometry, as you said so clearly, that it's anywhere on the top of the mountain or under the sea. As of today, we have reached a fantastic amount of biometry. The question is with respect to the dry cornea and the keratometry reading and the axis you're doing a toric.
Absolutely.
Dr. Hill, would you like to add something on that?
No, I agree with Doug Koch. For the magnitude of astigmatism, autokeratometry appears to give the best results. And we use topography, we use an axial curvature map to give us an indication of the magnitude. And because, astigmatism depends on both magnitude, and direction, you need a good interpretation of both. So topography, to manually look at the orientation based on the power distribution across the anterior cornea, not the simulated K readings. And then autokeratometry that meets validation criteria for the magnitude. And that's our go-to method for the toric IOL.
If I may, one query to Dr. Koch. I also believe in aiming at the nearest minus. But there is a thought process, especially with multifocals, that if you aim at the nearest plus, then the amount of dysphotopsia that these patients experience is a little less. Would you subscribe to that?
I think that's probably true for some. I think it's true for example, the Symphony EDOF lens. I'm not sure that that's true for the trifocal that I have available to me, the Panoptics. So I'll have to learn from you on that. Has that been your experience, Dr. Ramamurthy?
Not really. As I said, I also aim at, if I get 21.2, I go for 21.5. But there has been a suggestion from some other surgeons, some friends, that they look at the nearest plus and they leave the eye a little hyperopic. They say that causes less of divergence of the rays of light when it's hitting the macula, especially from multifocals. And theoretically, that might reduce the amount of dysphotopsia these patients have.
And it also depends too, I think, probably on what your patient's goal is. If the patient isn't driving at night, the last thing, you don't want to leave them hyperopic. You want to give them, if anything, a little bit myopic. They'll have more range of useful near vision. If the patient's driving a lot at night, they might not be a candidate for a trifocal anyway. So anyway.
Dr. Ramamurthy, I mean, I agree to disagree there because, by evening, if they can't see their WhatsApp messages and if they can't dial a number by evening, you're not a great surgeon. That's what it has come out to be now. So leaving them a little myopic is kind of the best option that I totally agree with on that count. Sir, what about the impression on the newer lenses? I mean, I'm going back on the mini-well and all, without which have no refractive on the front surface. They have the whole scenario which has changed. Would you have an opinion on that?
Well, I don't have any experience with those lenses, so I really can't comment. It is interesting that there are a lot of different variations now that are being introduced optically in our intraocular lenses. We started with diffractive way back when with the 3M. Then we went refractive with our IOLs with the AMO array lens. And I forgot the name of the one that succeeded it. And then we've gotten back to diffractive, but now some of the lenses have a refractive surface and not a diffractive surface. For example, the Vivity, the Mini Well, as you mentioned. And some of the companies are working on more sophisticated versions of non-diffractive optics as well. So it'll be very interesting to see where we end up with these lenses. We know we lose a fair amount of light with diffraction because of higher order diffraction. So it'll be interesting to see if the refractive lenses might retain more of the light and somehow give a better vision. Remains to be seen. The only one I have experience with currently is the Alcon Vivity lens, and I found that that's very forgiving in terms of glare for patients at night. There's almost no problems with glare. It does give distance. It gives you intermediate. You're not going to get reading vision by and large. But it's very forgiving from that standpoint. It's the least glare I've seen from any of the multifocal extended depth of focus IOLs.
Okay. One thing, we looked at the cornea, we looked at the lens, we looked at the retina. We have never bothered about the aqueous and the vitreous. You think somewhere along the line we're going to start looking at that too for refraction?
Well, we're certainly going to look at the vitreous for floaters because people who have multifocal, trifocal IOLs are much more severely bothered by vitreous opacities than patients with monofocal IOLs. So I think we're going to need to think about better ways to handle the vitreous going forward and see if we can. Are we going to be doing some more vitrectomies? I know a lot of my patients are getting them done just for the floaters after these, multifocal IOLs and EDOFs.
Since you brought it up, Dr. Dog, we in India have more experience with the iHands and Vivity is just being introduced. I believe the two lenses work on similar concepts. I mean, what has been your experience with the two lenses? How do they differ between the iHands and the Vivity?
I don't have experience with the iHands. I'm going to be implanting the first iHands in the U.S. In 2 weeks. So I don't have, but the Vivity I've had a very positive experience with, but I've tried it in some post-LASIK eyes. If the corneas are very regular, the Vivity works well, but I have one patient at least there's some asymmetry in the central 3 millimeters, and the quality of vision is poor. So I think that there is a little loss of nighttime contrast or low light contrast with the Vivity, and I think you have to be careful not to push the limits, thinking that it's going to be useful for, quote, all eyes. We still have to screen eyes just as carefully, I think, for that lens as we do others, whereas with the iHands, I think that'll be a lens for all eyes because it's just a very subtle surface change that gives a little bit extra range of focus, not as much as the Vivity, certainly.
Dr. Himanshu, may I ask a question here?
Please, Gaurav. Please.
Dr. Koch, I was enjoying your presentation, and there was one slide which said that cause of the refractive surprise most often now is not the axial lens, but it's the ELP and the errors of refraction. So that's always been interesting because I've read this on several studies before that we've gone from axial lens to cornea, and now while one can understand ELP, but errors of refraction, like how do you think that accounts for? Is that like post-op refractions which are going off the mark, or what's causing it?
It's just a reporting, I think, an issue with refraction. If you may measure 100 patients, and if you don't accurately refract 10 of them, you're going to have a 10% less than 0.5 diopters. So that's how refraction fits in. Refraction used to fit in because we used to optimize our constants and it would create it. But now I think it's just a matter of our reporting issues and the accuracy of refractions.
In fact,
if I might add one thing for those of us who develop lens power calculations, as Doug mentioned, the keratometry has the greatest variation. And if I had a wish list and I could fix one thing about what we do prior to cataract surgery, it would be better keratometry. But again, for those of us who develop lens power calculations, the final post-op refraction also has a lot of mathematical noise. And if you think about it, one click up or one click down off on the phoropter, if you have a lens with a constant of 119.0, that's a difference between 119.25 and 118.75. So as Doug mentioned, as a reporting issue, it's a really big problem. And a lot of practices don't really do a good, solid endpoint refraction, and it drives us a little crazy when we try and do the best we can for developing formulas.
There is quite a bit of ethnic variation between eyes, and very often these formula are brought up in North America, then we adapted. And of course, during the development stage itself, patients from different ethnicities are taken into consideration. And I'm told that nowadays even gender is taken as a consideration. Like Dr. Hill as well as Dr. Doc to comment on how important is this factor of ethnic variation, as well as is there a gender variation in the IOL power calculation?
Well, it turns out that we're actually, I'll go first here. It turns out that there is ethnic variation. The main variation we've been seeing is between ethnic Chinese eyes and Caucasian eyes. And that arose out of complaints from many of my Chinese colleagues that the formulas that they use were optimized against Caucasian eyes of European ancestry. And we have found a difference. That's the only difference we've found so far that's easy to identify. And as we all know, the ethnic Chinese eye has a tendency to be a little bit smaller in terms of the white to white, and the anterior segment may be a little bit more crowded. That's one reason why angle closure is so common in Asia. We're in the process right now of a multi-center study to actually develop an artificial intelligence model for the ethnic Chinese eye. And during my presentation, I'll talk about that just a little bit.
Warren, have you found anything regarding gender?
Yes, we did. It turns out it wasn't until we got above 30,000 lenses that we were able to figure this out. It's very small, but it is real. And that's been incorporated into the RBF version 3. Again, it's a very small amount and it can only be picked up with large numbers.
It's fantastic.
Brilliant. I guess we carry on the conversation a little later, Dr. Hill. Dr. Koch, are you still there for a little while?
Yes, absolutely.
Oh, wonderful, wonderful, wonderful.
I wouldn't miss Dr. Hill's talk. Are you kidding me?
Yeah.
You're very kind, Doug.
That's very sweet. Sure. Let me introduce our next speaker, very much wanted, Warren Hill. He's been in private practice in Mesa, Arizona for the past 30 years and has completed ophthalmology from Rochester, New York. And since then, devoted majority of a career to the challenging anterior segment surgery and mathematics of intraocular lens calculation. Knowing him personally, I know that he's a Princeton man. He's a mathematician, and at the same time, he's an ophthalmologist. So it's a great boon to the Ophthalmic Society. All those people, Steve Charles, who did vitrector, he was also an engineer before. And this is how beautiful it is that we have a combination of the best brains coming into ophthalmology and giving us various formulae. He's the best known for his work in helping physicians to obtain accurate IOL power. I mean, that everybody can vouch in the world. Anytime they have a problem, they would go on drhill.com and put up that free of charge. They would get an answer within 24 hours as to what their power should be. And the ASCRS post-refractive calculator developed with Doug Koch, both the stalwarts are here, and Lee Wong, are two most popular IOL power calculation resources in ophthalmology with a combined total of over 150,000 views per year. Now, Dr. Hill gave the ASCRS Innovator Lecture in 2015 and gave the AAO Charles Kelman Lecture. Now, that is something amazing. But more interestingly, as a human that I know him, he's also a great pilot. He loves flying. And some of his maneuvers, which have been tremendous, 3 people flying almost 10 feet apart at that speed and landing nose down and then going up. He has this crazy thing of absolutely revolutionizing thing and meticulous to the last extent. I mean, when you're doing that kind of maneuvers at this stage, and I realize he started at the age of 52. That's amazing. He's also got into flying, and he's got his mathematics going in his brain constantly. Over to you, Dr. Waddington, and thanks for being with us this morning.
Okay, well, thank you very much. Let me just bring all this up here. And all right, just want to confirm that you can see my screen.
Yes, sir.
Okay, good. Okay, well, let's talk about IOL power selection driven by artificial intelligence. And, artificial intelligence is becoming one of the most important things, not just in ophthalmology, but also in medicine and, of course, around the world that we live in. So we're going to talk about this as it applies to lens power calculations. So really, for any plan involving cataract surgery, how can we be most effective? Well, we want to avoid complications. So the most efficient surgery and the best loved surgery is one without complications. And when we think about complications, we think about these sorts of things: an IOP spike after surgery, an incision leak, perhaps a CME later on down the course, or retained iris fragment, heaven forbid, endophthalmitis. But actually, if you look at the numbers, an unanticipated refractive outcome would be the most common complication following routine cataract surgery. And that could be for a very picky patient, as little as a half a diopter, or for a more forgiving patient, perhaps 1 diopter. So as anterior segment surgeons, we're really being judged by our patients and our peers by our refractive outcomes. We're all pretty much doing the same type of cataract surgery. We all have very good results. We all use self-sealing incisions. So I would put to you that the elephant in the room when we do cataract surgery is really IOL power selection. And this is a place that all of us as anterior segment surgeons need to turn our attention. Let's talk a little bit about accuracy standards, and Doug Koch touched on this. And the question is, should what's common, be good enough? And these are some very well-known studies that Doug had mentioned. For a half diopter, we're still around 78 to 80%. And for those of you who track your outcomes, these should be very familiar numbers. For the 1 diopter accuracy, we're doing quite well, and I think we've pretty much hit the mark there. So we can use the Haggis formula optimization database, which is now over 300,000 cases. And this is the gap that we're looking to close. And once you begin to get into the upper realms of IOL power calculation accuracy, improvements are really painfully incremental. So this is graphically what 78% looks like. And for those of us that do toric lenses or multifocal lenses or have particularly demanding patients, this probably isn't good enough. Now, let's go back to the very beginning so we can see where we've been and then talk about where we're going. And this is familiar to all of us. This is Carl Friedrich Gauss's Virgins formula from 1840. And he was a German mathematician and physicist from the mid of the 19th century at the University of Helmstedt. And fast forward to current formulas, and as Doug showed us, this is basically Dr. Gauss's Virgins formula. The lens virgins equals the image virgins equals the object virgins. And we've added some more modern aspects to it, keratometry, refraction, IOL power. But one of the difficult parts is the power of an intraocular lens inside the eye is relative and not absolute. If it says 21 diopters on the box, it's only 21 diopters at a predicted distance from the cornea, what we know as the effective lens position. And if you take a 21 diopter lens and the formula miscalculates its effective lens position by 0.5 millimeters, that's a 1 diopter error. And if you try holding your fingers 0.5 millimeters apart, you can see how sensitive this whole process is to the effective lens position. And as Doug mentioned, Svecker Norby showed that one of the greatest errors for IOL power calculations is the effective lens position. Also, the effective lens position can only be estimated. It can't be calculated exactly. If it could be calculated exactly, we'd all be using ray tracing, which is probably the very best approach if we have this information. So this is a stumbling block. And when we began to look at alternative ways to do IOL power calculation, the idea was to leapfrog over the effective lens position and make it not part of the process. To keep things in perspective, here's a series of 3,400 patients. We're going to use the SRKT formula, which is one of the most popular formulas in the world. Here's our half diopter accuracy. And here are cases outside that half diopter accuracy. And obviously, we have a long way to go. So we need to think differently and perhaps use something that doesn't rely on the effective lens position and some of the other limitations of theoretical Gaussian formulas. So we really need to look no farther than the smartphone you may have in your pocket. And those of you who've set up your iPhone, remember this little screen. It says, place your finger on the home button and put it there repeatedly. And what the iPhone is doing is it's memorizing a pattern for your fingerprint that's unique to you. And of course, here's what it sees, and it comes up with a pattern that identifies you and then can allow you to either access a credit card or access your phone. This is pattern recognition. And in medicine, pattern recognition is used extensively now, not only in ophthalmology, but in other areas. The cardiologists use it. And what is an electrocardiogram? Really, it's nothing but a pattern, isn't it? And here's a pattern that's a little worrisome. This is called T-wave alternans. And if you have microvolt variations in the T-wave from one beat to the next, this can be a signal of a fatal cardiac event. So interpretation of electrocardiograms is now using artificial intelligence and also pattern recognition. Now here's a little example that some of you may have seen before that shows the power of this technology. And we have a little square here, and inside this square, we're going to place seemingly random points of 1,000 of them, but they're not really random. They're using something called a Manhattan distance generator. And if you think about the city of Manhattan with its city blocks and the buildings on those blocks, if you wanted to drive from one part of Manhattan to the next, that's called the Manhattan distance, or in mathematics, it's also called the taxicab distance. We can't drive directly through the buildings, we have to drive around them. So this is the pattern that underlies this seemingly chaotic collection of dots. The Euclidean distance would be the way you would go from one point to another as the bird flies or as the bumblebee flies. So we're going to give our artificial intelligence algorithm 5,000 chances to see if it can come up with the right answer. And with today's computers, that might be just 1 or 2 seconds. And here we are in the beginning. This is about 40. Here's about 250. Here's 500. And by 5,000 observations, the artificial intelligence algorithm has actually been able to uncover the underlying pattern of a seemingly chaotic and random presentation. The power of this is just astronomical. And if we're looking to uncover difficult nonlinear relationships, this is a very good place to start. So the question we would ask is, why not intraocular lens power? So moving forward with artificial intelligence, what are its advantages? Well, it's adaptive learning, and it has a highly sophisticated form of pattern recognition and outcomes optimization based solely on data. And as we all know, manual optimization methods limit possibilities to situations that we already know. We usually do what we already know how to do. Pattern recognition is well suited to real-world problems where ideal models are not available. And lens power calculations is the poster child for that concept. As we showed in the last slide, it's self-organizing, and it has the ability to create a novel representation of the data, and it has enhanced sensitivity for identifying and unraveling complex nonlinear relationships. It may turn out that the patient's age and keratometry have a relationship. The only way to figure this out is by different novel methods of analysis. And what I like a lot is that it's free of calculation bias. And this is especially important for the high axial hyperope. And we'll go into that in just a minute. So let me walk you through how we develop a real world artificial intelligence calculator. And perhaps there's somebody in the Indian society who's watching this that may take inspiration from what we're talking about and will do a better job than we have in the years to come. So step one, which measurement should we use? And in the very beginning, Doug Koch and his colleague Lee Wong and I played with a lot of different preoperative measurements, including the 6 millimeter spherical aberration, pupil size, age, gender, a lot of things. And we came up with 13 possible preoperative parameters. The question is, which of those matter? Because we know that there may be relationships that we haven't even thought about that are important. So we used a genetic algorithm, which is an evolutionary iterative factor selection process. And we create a basic model, and then in a semi-random manner, we create new models, and then we look at the outcomes. And then the best performing candidate models are identified and ranked, and then we move on to keep doing this over and over and over again until we come up with the best solutions. And what we found is, for a given IOL power, the postoperative spherical equivalent, the axial length, the central corneal power, and the anterior chamber depth gave us the highest overall accuracy. And Doug Koch's colleague, Li Wang, told us that for an independent validation set, we had to be above 90%, or else we're all going home. This exercise isn't going to work. And so for the second option right here, this met the criteria. And we'll talk about out of bounds points in just a minute. So also during the process, we have ways to evaluate the different ways in which we could look at this with artificial intelligence. There are many different types of artificial intelligence. It's not one thing. There's a part of the artificial intelligence modeling process that includes something called an activation function, which is in the hidden layer of the artificial intelligence algorithm. And there are different types. There's Gaussian process methods, stochastic process methods, polynomial models, just lots of different ways. And what we found was that a radial basis function for the activation function gave us the best outcomes, and that's where the term RBF comes from. And we were able to make very high quality models using this form of artificial intelligence. So next, we need to fit real world data to the artificial intelligence model. And for this, we need lots of data. And we began with Doug Koch and his colleague Li Wang at Baylor University and a number of ophthalmologists in the United States. But it was obvious that we needed very large numbers. And we currently have put together a worldwide collaborative effort with 44 participants in 20 countries in North America, South America, Europe, the Middle East, Africa, India, and Asia, and Australia. And Dr. Luthra was actually one of our very enthusiastic beta testers early on in the project, and he had an Excel spreadsheet with the RBF method before this even saw the light of day in a more usable format. So 44 participants in 20 countries are feeding us data, and many of these physicians represent the most accomplished cataract surgeons in their respective countries, and we're very grateful for their input and for their help. So now we know what factors we want to use. We want to use the axial length, the central corneal power, the anterior chamber depth, postoperative spherical equivalent for a given IOL power. We're going to apply the radial basis function activation functions in the hidden layer of the artificial intelligence modeling process. And then what we get is, from the output layer, is an IOL power, and we calculate the difference between this output layer and the fitting data set. And then there's a backward propagation process by which we keep going through this over and over again until the accuracy doesn't improve. And then that's the model creation for that particular data set. We start out with a small data set because we're limited by data, and then as additional data comes in and is validated, we go through this process again. So early in the process, we were able to take a cloud of data and turn it into a straight line. That was impressive. And also, if you look at the half diopter accuracy, those cases in the beginning that fell outside the half diopter accuracy were just based on numbers. There was really no bias. So it didn't perform necessarily less well for short eyes or less well for very long eyes. So there's no outcomes bias. Some of the limitations for the very short eyes, as Doug mentioned, have to do with the effective lens position, and those are the most problematic cases we have for IOL power calculations. Now, in working with the engineers and mathematicians at MathWorks, what we discovered was that there's some other tools that we can use in ophthalmology that engineers know all about, but ophthalmologists don't. And one of the jokes we like to say in ophthalmology is, if you want to solve a problem in physics, optics, and engineering, you don't ask ophthalmologists, you ask physicists, engineers, and optical engineers. And this is an example of that. One of the mathematicians we were working with said, well, gee, how do you know beforehand how well you're going to do? And let's create a boundary model. So in engineering, this is a very common tool where you look at pairs of preoperative or measurements in ophthalmology. This would be central corneal power against axial length. And what we can do is we can detect the edge of these boundary models outside of which a certain level of accuracy cannot be predicted. So this is the boundary model again for central corneal power and axial length. And here's the edge of that boundary model. And all of these cases that are outside that automatically invalidate the measurement or the calculation if you're looking for an accuracy within half a diopter of 90%. So what we've developed is a method by which we can tell the surgeon prior to the operation what are his chances of having a good outcome. So a case with this data point would probably be an out-of-bounds calculation because we don't have the data to support it at a certain level of accuracy. So we put together our first calculator, and this is the one that Dr. Luthra had a chance to work with on us. And we did a prospective evaluation, 3 study centers, 459 consecutive cases, a wide range of IOL power, axial length, ACD, and central corneal power. And what we came up with, it turns out, is pretty much what we predicted. For all eyes, we were around 90%, which is what our boundary model prediction told us we would see. For normal eyes, just a little bit better. For axial myopes, as Doug Koch mentioned, these we do very well for because the effective lens position is less of an influence. And then for axial hyperopia, we did very well. Now, these were eyes at 22.5 millimeters rather than 20 millimeters, 22 millimeters rather. And the reason we chose that is we just didn't have enough cases because it was a relatively small data set of only 459 cases. But it still impressed us. And to this day, this particular calculation method works very nicely for the axial hyperopia. Other people began to look at the outcomes with this, and this is version 1, again, only based on about 3,400 cases. And Roman and his group, which I don't know Dr. Roman, but he presented this at IIRSI, got pretty much the same thing that we did. So if we use the inbounds cases, the boundary model is very helpful for guidance, and it will tell us what our chances are for a good outcome. So let me just show you how this boundary model works and how it can offer guidance while you're doing your calculation. So this is version 1, 3,400 cases. We're going to take a mild axial myope. We're going to have normal Ks and a normal anterior chamber depth. And you can see that all of these data points are in the middle of the boundary models. So this would give us an inbounds calculation. Here's a 28 millimeter eye, a little bit longer, and we're going to look at some crazy parameters here. Very steep Ks, not keratoconus, but very steep Ks, and also a very shallow anterior chamber. So this would be a little unusual for a high axial myope. Well, for version 1, we didn't have enough data to do this calculation at a 90% accuracy for half a diopter, so it gives an out-of-bounds calculation. So let's look at version 2. This is now about 12,400 cases. And what we've done is we've expanded the boundary model, both the number of cases and the types of cases. And here we're going to have a very long eye. And this is the same case we just looked at a minute ago. And now that the very steep case becomes normal because we had a greater number of cases. And here's our shallow anterior chamber depth. But because the boundary model had been expanded, it's now an inbounds calculation. And we can tell the user that there's a 90% chance that you'll be within half a diopter. So what happens if we do have an out-of-bounds calculation? Well, that can begin a dialogue and a discussion with the patient. We can say, Mrs. Jones, God has given you a very unusual eye. We're going to do the very best we can, but just know we may not be able to promise or or think about the level of accuracy we might have with an eye with more normal parameters. So it allows us prior to surgery to have that conversation with the patient. Now for version 3, which was just released last month, I'm very excited to talk about some of the changes that we've made. This was a 2-year effort with our study centers around the world and with a full-time PhD mathematician. And let's take a very unusual eye. Here's an extreme axial myope, very flat case, very deep anterior chamber. And you can see that with the expanded boundary model and a refinement of the database, this is just plain vanilla. This case comes up in bounds. And so the number of out of bounds calculations for version 3 is very, very small. Now we have an online calculator. This is available to the worldwide ophthalmic community at no charge. And it's at rbfcalculator.com. And you can go to this site, you can click on, what is this? And it will give you an explanation of what it is that we're doing. And if you're interested in, all the details of how this type of calculation works, you can click on this link and it will go through all the crazy mathematics involved in this form of artificial intelligence. You can enter the calculator and then put in the patient data. And this was sponsored by Hog Strike. And out of an act of tremendous generosity on their part, they've made this available for every type of biometer. So let's say you have an iMaster 500, which doesn't have the additional parameters that this uses, it sets up for that. So Hog Strike has made this available for all surgeons and all biometers around the world, which I'm very pleased with. We put in the basic patient information, their measurements, some information about the IOL, and then it will give us the calculation. You can see for this extreme axial hyperope with an axial length of 19.62 millimeters, we still have an inbounds calculation for -1/4 for the target refraction. But we do have some out-of-bounds calculations. And version 3 has been expanded reliably up to 34 diopters, and we're still getting inbounds calculations as far as +36 diopters. So this has been expanded greatly. As far as lens constants go for this particular calculation method, thanks to the input from our study sites around the world, we now have optimized lens constants for pretty much every popular lens used in Europe, North America, Australia, India, and Asia. And we're still in the process of optimizing lens constants for new IOLs. So just quickly to review, the March of 2018 was version 2, and we were able to extend the calculation range down to -5 with meniscus lenses and expand the boundary model. This newest version, version 3, we've further expanded the boundary model, and we've extended the range reliably to about 34 diopters. And we now have improved accuracy for unusual anterior segments. And for this, you need the central corneal thickness, the white to white, the lens thickness, and gender, which actually does make a small contribution. So these are additional measurements. And instruments like the Lens Star and the iMaster 700 and some other biometers actually give us this information. Now to show how much of an improvement this is, we're going to look at a high axial hyperope, and you can see with version 2, every one of the calculations is red, which means it's out of bounds on this Excel spreadsheet. For version 3, every one is inbounds now. We look at a high axial myope, in this case an extreme axial myope. In version 2, we have limited options for the refractive target. For version 3, all options are inbounds calculation. And as is typical of Hog Strike, prior to its release, we did extensive analysis. This is close to 10,000 cases from study sites around the world. And what we found was that for version 3, we were about 1 to 2 percentage points better than version 2. And a lot of these cases were unusual eyes with highly odd anterior segments. So that's where this formula really performs, is for the high axial hyperope and also for the unusual anterior segment. So the future, ophthalmology is experiencing a convergence of technologies for IOL power selection accuracy, ray tracing, artificial intelligence, advanced convergence formulas like the Barrett Universal 2 formula, as Dr. Koch mentioned, and also interoperative aberrometry. But the method with the greatest sensitivity and flexibility will give the greatest accuracy as technology advances. And really only time will tell, what that will be. And every few years, there's another breakthrough, and we do a little bit better. What I'm hoping for is our measurement technology gets better. And for those of us who develop lens calculation methods, this is going to make our job a lot easier. And 78% is tolerable, 84% is acceptable. And I'm here to say that we can probably get in the 90% range if we're very careful with our preoperative measurements and use the best calculation methods. And one thing that we found is that optimization of the ocular surface prior to biometry really has a big influence. It makes the gaze more stable and lessens the mathematical noise of the exercise. And this is what we talked about before. This is about 78%. Again, we can do a lot better than that. This is 90%, which I would say is achievable if we really take our time with the measurements and use the best calculation methods. And this is where I hope we can go. And those of you who are as old as I am, and perhaps Doug, you probably remember when we went from immersion ultrasound to optical biometry. How many of you now worry about the axial length when a patient has a relatively normal eye? We pretty much just accept it at face value as long as we validate it. Well, I think in the future, my hope is that lens power calculations can move and shift into that category where we have the right kind of measurements and the right calculation tools so that we won't have to worry about the spherical equivalent for the refractive outcome, and we can turn our attention to other aspects. And that pesky elephant in the room every time we walk in the operating room and implant an IOL will eventually fade away, and we can turn our attention to other, more pressing issues that have to do with eye surgery. Thank you.
Thank you so very much, Dr. Warren. Wonderful presentation. But before we take a few questions from him, let's hear a major part from Gaurav too. Dr. Gaurav Luthra is a very prominent surgeon in India and a very scientifically oriented human and excellent coordinator for multiple activities for IIRSI. He has the Drishti Eye Institute in Dehradun and has been the past president and chair of the academic IIRSI. Without spending more time, I invite Gaurav for his presentation. Gaurav, thanks for being with us this evening.
Thanks, Dr. Imanshu, Dr. Rohit. In front of Warren and Doug, I don't think I should be, speaking at all, but I'll try to fill in what you wanted me to fill in with some of the other things which are available today, the newer formulas which are coming up, and I won't spend more than 5 minutes on it, so that we can have a good discussion. So thanks for giving me this opportunity, and I've enjoyed both the talks so much. So here goes. So, and by the way, Himanshu, I think you forgot to mention that Warren is also a big ham radio freak. He was in Vietnam in Burma for a few years, setting up for the government ham radio networks. So I mean, then his wife has gifted me a beautiful version of the Bhagavad Gita, and she's translated into English, and that's so amazing. My mom loves it. So
he's also well read. So exactly, that Bhagavad Gita is a great piece that even I've been reading. And Burma, he had problems getting back into the U.S. immigration authorities.
Yes.
Let's go. So I think we've already gone through this, so I won't spend much time. We've all gone through the first generation, the second generation, and the third generation, and the fourth generation formulas, and then the newer formulas which are coming up, and even newer ones which are, which even Doug Koch spoke about. And this is how it looks. And I've been so excited to be involved with the IIRBF, as it grew from the Excel sheet to the online calculator to the integration into the LensStar. And then I've been working with the LensStar for many years. And only like 2 weeks back, my LensStar got upgraded to the IIRBF 3 and the posterior corneal curvature, integration. And it's so exciting. I'm enjoying, playing with the machine now and for all our patients. So this is how it looks. I mean, for the normal eyes and all kinds of eyes. And you can see here that at the bottom of the stack is the Barrett's calculator and the Hill RBF, which can go really far for the short eyes and the long eyes. I've really enjoyed the Hill RBF for the long eyes because it seems to work best for me, better than any of the other formulas for the long eyes, and now also for the short eyes because it's really enjoyable. And frankly, let's go on. So Olsen formulas, this is for the sake of completion of what we have, other than what works best right now and what's coming up probably. So we all understand that the Olsen is based on the ray tracing principle with a C constant, and it's a fraction of the lens thickness by which the center of the eye will locate itself post-operatively. And this concept was published in the JCRS, and it is thought to be the new ray tracing principle. And I won't go into the details because for quite some time, and I don't want to go into a theory of the formulas, but I think we've spoken a little bit about the Olsen before. And that brings us to the artificial intelligence and the Hill RBF calculator, which I've personally been working with for many years. And as Warren said, I was involved with the initial part of the study, and then we've seen it grow. And I'm seeing the Hill RBF 3, and we'll see the advantages of that. So as we all understand, we've just had a talk. I will not talk more about it. What I love about it is the out of bounds feature, and that tells you sometimes when you have an eye which may have peculiar measurements, because it may look normal, it may have a normal excellent to initial exam, and it might look like it looks like a normal eye, and other formulas are not going to predict that this is going to be possibly an eye with a refractive surprise, but the Hill RBF will immediately label it as out of bounds. Of course, now that Warren has a huge database, so the number of out of bounds are going to be really small. But till we didn't have this bigger database in the Hill RBF2, we would occasionally have an out of bounds eye, and that would immediately make me, kind of watch out. Is this eye potentially, why is it showing out of bounds? And you might sometimes see that the AC depth is suddenly much smaller for an eye which is much longer, or maybe the keratometry is a little off for an eye which otherwise looks totally normal, and that would suddenly put these eyes at risk of refractive surprise. And that has saved us many a times for situations where we looked and relooked and then went more carefully and got a good result. So the Barrett suite is something which also has become very popular, especially with the Allmaster 700 integrating the Barrett suite into the system. So the posterior surface of the cornea gets included in the Barrett suite, and it includes 3 of the formulas, typically the Barrett's Universal 2, which is all for the non-toric IOLs, the Barrett's Toric, and also the Barrett's True K for all the non-torics after refractive surgery. And the Barrett's Universal 2, of course, is Burgess-based formula. And we all understand that it's based on the model eye in which the AC depth is related to the axial length and to the keratometry, and it takes into account the A constant and lens factor, which helps determine these formulas. And it frankly works really well for all kinds of eyes. And this has become a very, very integral part of the biometries of all optical biometers. And a huge number of people in India, at least, are using the Barrett's Universal 2, and they depend on this for the reason that it is integrated into their biometers to a large extent, and of course is available online as well. So again, this has been accepted as one of the most accurate IOL formulas today. And as we understand that, it has come a long way today. And let's go on to what all it requires. What is essentially required for the Barrett's is the axial length and the keratometry and the lens factor. And of course, if you would also put in the AC depth, the white to white, and the lens thickness and the design factor, it would obviously increase the accuracy. So the lens factor is calculated out of the SRKT, whereas the design factor is IOL specific and definitely influences the IOL calculation. And as we understand that the precision can be much more if you have the design factor of the specific IOL that you're planning to use. Again, if you also have these 3 parameters, it will increase the accuracy, just as the Hill RBF 3 has taken into account some of the new things with the corneal thickness and the white to white, and those variables that Warren spoke about, that initially when we started out, we just wanted to choose those 4 variables, which would give us very few out of bounds. And now that we have a huge database of patients, you can add these for more precision and lesser number of out of bounds eyes. Same way for the Barrett's, I think it works out that it becomes more precise when you have more the lens thickness and the AC depth put in for predicting the lens, the better IOL prediction. Now the Barrett's toric calculator, I think it was something which really revolutionized our toric implantations, and today I think almost all company formulas have started using some form of derivation from the Barrett's toric calculator for their own calculators, integrating the nomogram for the posterior corneal astigmatism, and which is not really measured, but it's derived from the anterior keratometry. It uses basically a nomogram to predict the posterior corneal measurements and uses that for the calculations, and it has shown excellent results. And today I have used the Abulafia Koch calculator, which also comes on the Lenstar, and I've seen that the Barrett's toric and the Abulafia Koch, they both compare pretty well. And these have really changed our way of understanding. And today we do an toric calculation for all patients, and even those with the smallest of astigmatism. And it's surprising to see that occasionally there'll be patients with just 0.5 astigmatism where we'll end up implanting a toric lens, and there'll be others because of the difference between the with the rule and against the rule astigmatisms. So I think, again, most people are using the Barrett's toric calculator today. And then, of course, coming on to post-refractive surgery, I think the True K formula is something which is very, very useful today. And amongst the gamut of few formulas which is there on the ASCR calculator, as well as onto our machines, where the Shamas and the True K, we really have started using more and more of the Barrett's True K post-laser vision correction formula. I will not go into the details for the sake of brevity, and it does perform well. So another thing which gets integrated with the IOLMaster 700, and I'm not a user and I have no financial interest, is the total corneal power. So it gives you the TK. Now, there have been mixed opinions about the value of the TK, as Dr. Douglas Koch as well pointed out about its utility for healthy normal eyes. But definitely when you come to post-refractive surgery eyes here, the measurement of the posterior corneal curvature will make a difference. And so it basically gives you additional data, and instead it replaces the posterior model with actual posterior measurements. And that results in two new formulas, which is the Barrett's TK Universal 2 and the Barrett's TK for the toric. And I think it has a place, at least for the toric calculations for sure. And one should definitely look at it, but whether to use it or not is something that you have to take a judgment yourself. And coming on to a couple of the other formulas which have also been pretty useful of late, and they're coming up really well, is the Super Ladders formula, which actually incorporates many of the existing formulas into a single equation, and then it picks which formula might work best for you. So it also incorporates data, and it's in real time that it's growing with more and more numbers. And it kind of tries to visualize the formulas in 3 dimensions. And it's a novel approach because it kind of uses different formulas and then try to see and improve upon them to give a kind of a personalized kind of a measurement for you, a personalized constant. In that way you can derive, or from the benefit of other users around the world, where you can kind of grow onto your own formula and come out with a better result. The Kane formula sounds exciting too. And it kind of was in few studies has been shown to be very, very accurate. And it was came up in September 2017, and with almost 30,000 highly accurate cases. They have a formula for the toric formula as well, and they have one for keratoconus as well, which is derived from the regular Kane formula. And it has the fields of the A constant, it has the gender, the axial length, corneal power. So as we were talking about gender, so this one includes gender, and the anterior chamber depth, and you can add the lens thickness and the central corneal thickness, which will improve the prediction, but it's not compulsory. So this again has been a formula in evolution, and supposed to be, many people find that the Kane formula is supposed to be very good. There have been studies which have shown that big advantages of using the Kane formula over the others. This was one of the studies which I could find. It concluded that using 3 variables, the axial length, the keratometry, and the AC depth, the Kane formula was more accurate predictor of actual post-op refraction than the other formulae, where they compared it maybe even to the Hill RBF2, the Holiday 2, the Olsen, the Barrett's Universal 2, the Hager's Holiday 1, Hoffer Q, and the SRKT. Now, of course, different studies might come up with different results, but this was one of the studies which showed up. And then we have my friend Pam's formula, who is contributed to this, the EVO formula, which again is thought to be one of the contemporary very good formulas. And it is known as the emmetropia verifying optical formula. It's basically based on the theory of emmetropization and generates an emmetropia factor for each eye. And we won't go into the details, but this is another formula which is available online. And this is the fields which are required for this formula. So this can definitely be another formula which you can consider. We have our friend from India, and who's worked with Dr. Vavikar, who was supposed to be on the panel. There is Saurabh Sani, who has developed a toric calculator along with Dr. Vavikar, and he's been working on artificial intelligence. And as Dr. Warren said, that he's excited about somebody in India who might be working on, the concepts that Warren has kind of brought forward. And he has been working on two different artificial intelligence systems. One is his formula, which he currently says that he's still, it's an evolution. and he's also working on dynamic IOL optimization, where it kind of maintains your. It's like for developing a personalized A constant, and it constantly gets updated with your own results using an Excel sheet, and can grow your, give you more kind of personalization. So with that, I think I'll come towards the end of my presentation, trying to give you a hint into what new formulas are doing. But I found this one study which compared the accuracy of 11 intraocular lens power calculation formulas. This is published somewhere in October 2020, and where they have compiled data from 481 eyes and compared many of the formulas, so almost 11 of them. And they tried to say that, as far as the results goes, they found Barrett's Universal 2 and the Haigis. Now, obviously, this did not include the Hill RBF3, which will probably change things a little bit. But these the Universal 2 and Haigis yielded length range, as well as in the long and the normal. And in the short eyes, they found that the Haigis and the Evo formulas seem to perform really well. So this is how it went. And I think with that, I would like to lead on to the discussion, and I'll stop sharing my screen now. So
Thanks very much, Gaurav, for a lovely quick presentation, a bird's eye view of what's happening around. Brilliant coverage in a very short span of time. Welcome, Bobby, for being there. And Dr. Hill, now that we have this lovely formula, would you have, you collected data across the world. Would it matter if you have the Caucasian eye, the Asian eye, or the European eye? And would that strangulate your data, or would you be doing separately for people?
Well, most of our patients are of European ancestry. We have some pretty large databases from India, down in from the group, the Arabic group in Tamil Nadu. But the majority of patients are European. For the ethnic Chinese group, we have databases from Hangzhou, from Shanghai, from Hong Kong, Taipei, and Singapore. And so those are exclusively Chinese eyes. And so we'll be concentrating on that for the Chinese artificial intelligence algorithm.
So those eyes would be different, behaving differently than the other eyes, possibly.
Well, what we found is that if you talk to somebody, say in Hong Kong, who does multifocal lenses, they have a different idea as to which formulas work better, because as we mentioned before, the anterior segments of many Chinese eyes tend to be a little smaller and a little bit more crowded. And I think it has an influence on lens power calculation. And so I've looked at many Chinese databases, and with formulas like Haigis, they do very poorly. They don't do well at all because the lens constants were optimized against European databases. They like SRK2 for some reason. That seems to perform well. It's a favorite amongst the Chinese ophthalmologists. And maybe it's just because they're using something that's older and they're familiar with it, or maybe it's because they like it. But the universal feedback that we get is that our formulas that come from European databases are not really all that good for the Chinese eye. What's interesting is that not all Chinese eyes are myopic. The classic eye that we think about has a little bit smaller anterior segment and a larger vitreous cavity with a population mean value of myopia. But a number of databases that I've looked at from different portions of China, there are a fair number of hyperopic eyes as well, which is interesting. So there's really a wide range. At the moment, we're just sticking to mainland China because I think there may be some variations amongst Japanese and Koreans or Cambodians, Vietnamese, Laotians. We're going to use that as our prototype and then go further into it as time goes on. It's been a little difficult getting really high quality databases from places other than Singapore, Taipei, and Shanghai. So it's kind of slow going right now.
One question which I would like to ask is, for post-refractive surgery, how's Hill RBF version 3 placed?
Well, it turns out we can't use that at all, because for artificial intelligence to work, we have to have good metrics. And as Doug so eloquently pointed out, we really can't measure these corneas. And it has to do with the Gould-Strand ratio. Many of these eyes have a widely variable power distribution across the anterior segment, across the anterior cornea rather. And so the Gould-Strand ratio may be different in different ways in different places. So until we can accurately measure the cornea, I think artificial intelligence isn't really going to play a good role, because so many of these eyes, whether they've had LASIK, ALK, PRK, radial keratotomy. Each eye is unique and individual in their own way. So we're going to need better metrics before artificial intelligence can be used. At the moment, I think the Barrett True K method for radial keratotomy, for myopic and hyperopic LASIK is probably giving us the best results. And our results are in the mid-70s, just like Dr. Koch showed.
I would just sort of add to that even if we come up with great measurements of corneal power in these post-LASIK eyes, because there's variability of power, we don't yet understand how to translate all that variable power into what the patient will select for the IOL or select for the refraction. So there's a whole nother step that needs to be done once we get great measurements front and back, and then trying to interpret it. So we have a ways to go in this setting.
And Doug, I think what you're saying is these are multifocal corneas. And what we think it might be the right power, the patient's using something different, like keratoconus. They don't look through the cone, they always look through an area kind of adjacent to it. And so what the patient chooses and what we choose, there may be a disconnect. So I agree with you completely on that.
Can I chip in with a question here? Sorry, Dr. Ray, please go ahead.
Please go ahead. Please go ahead.
So this led me to think that there was a situation where I sometimes get stuck is when we have a refractive surprise and I want to go back and post-operatively then we have the benefit of better measurements because you have a pseudophakic eye, and then if you have an occasional refractive surprise and you do a post-operative lens stuff, for example, and I want to look back where you went wrong, and then what do you recommend, Dr. Koch and Dr. Hill, because we can't use the Hill RPF, it can't work on pseudophakic eyes, right? And then we are stuck with the Barrett still work and the SRKT might still work. So what do you recommend that if we have a refractive surprise and we want to go back and we now have more pure data because we have an eye with a better optical system and better measurement of all the parameters, what do you suggest?
Well, I'll go first with this. Basically, a pseudophakic eye is now, we look at it as an existing optical system. So you would need to add power to or subtract power from an existing optical system. And that is actually a very accurate exercise, but we don't base it on the axial length. You would use either the Barrett RX formula or Jack Holliday's refractive versions formula. It would mostly be based on the effective lens position, a careful manifest refraction, and to a small degree decays. And that's probably one of our most accurate methods. So I would advise against remeasuring the eye and using a theoretical formula to come up with a new IOL power. Doug, do you feel the same way?
Completely agree. And this is one situation where absolutely I do the refraction in those eyes because the refraction is the driving force for the entire calculation. Once you know they're off by 0.75 diopters, you have to change the IOL, probably by a diopter, etc. So not something to delegate to a beginning technician.
Especially
can I make a comment?
Yeah, please
I think these pseudophakic eyes, I've used Aura as a major tool in these cases. And I found Aura really helps in these cases and gives you a good calculation, especially in a patient with a surprise.
Especially when you're planning to do the second eye of this patient where you had a refractive surprise and you don't want to go wrong with the second one, that's where it really pinches you and you're kind of stuck with a situation where how to plan the second eye, and that's why this question.
Well, there's another way to plan the second eye. A lot of people will take, say, perhaps 50% of the error and apply that to the second eye. But let's say the two eyes are symmetrical, and we see this mostly with axial hyperopes. What's happened is that the formula has probably misestimated the effective lens position. That's one of the most common issues. So what you can do is you can adjust the lens constant for the first eye until you can duplicate the refractive outcome, the refractive surprise. And then take that adjusted, customized lens constant and use that for the calculation of the second eye. And what we're doing here is we're giving the formula the opportunity to come up with the right lens power based on an effective lens position that more accurately matches the anatomy of the eye rather than the basic assumptions of the formula. And for the high hyperope, this works very, very nicely.
Thanks, Gordon. I think that makes sense.
Yeah. One question. I'd like to reiterate what Dr. Ramamurthy had already talked. The eighth constant, the eighth parameter you have included is the gender. So I would like you to inform each one of us how different are the formulas? How are different are the results when you take off the gender part of your, the type, the version 3 of your formula?
It's a very small amount. It's about an eighth of a diopter. But when you're looking at very large databases, you add whatever you need to make the outcomes better. So is it a significant factor for lens power calculations? The answer is no. Does it add something additional? The answer is yes. And is it a hard parameter to gather? No. You just look at the patient. So since it does add something of value, small amount, of course, it's easy to get. Why not use it? But as I mentioned, it wasn't until we got into tens of thousands of patients that we could actually see that this actually did matter.
Yeah, I fully agree because trifles make perfection, and perfection is no trifle. So small things are going to make it from 90 to 200, as you said. So these are
as I mentioned before, once you start approaching 90% for half diopter outcome, I can tell you that all improvements are painfully incremental. In order to get a 2% improvement over version 2, it took 2 years and of like 10 to 30 hours a week for 2 individuals. So this, I think, as Doug alluded to, we're sort of limited by our measurement technology. And there's kind of a biologic floor and a calculation ceiling for how far we can go. And until I think we have better measurement technology, we're going to be bouncing around with the same measurements, the same outcomes. And this is one reason why you might see 5 studies and see 5 different results. It's the measurements. It's not as much the calculation methods as it is the measurements. And we need to get the Ks much better. I mean, that's, like I said, if I had a magic wand, that's what I would want.
Corneal measurement. You're talking about the cornea measurements of the K readings, right?
Right. The keratometry has a tremendous amount of mathematical noise. And if I mention something again, in our practice, we optimize the ocular surface for 2 weeks prior to biometry. We have the patient do warm compresses that helps express the contents of the meibomian glands and stabilizes the ocular surface. We do lid scrubs, perhaps to open up the orifices of the meibomian glands. And then also we do high quality tears frequently throughout the day. And I can tell you that the consistency of keratometry is remarkably better on a topographic axial power map. Those multiple little flat and steep islands that you see, they all disappear. The aberration profile looks better. It really looks good. And let's say somebody has meibomian gland dysfunction that's significant. We might even do a lipoflow treatment on them to encourage the meibomian glands. And it's a significant factor in making these eyes better for the keratometry.
Himanshu, can I ask you a question?
Ramu, Dr. Ramurthy, you're muted. You were speaking.
Dr. Bhavikar is here. We can,
Can I? Bhavika, you want? Please go ahead. Dr. Hill, I just want a clarification regarding your concept of out of bound. I think it's a great concept. But with your Hill RBF3 iteration, I think most eyes that we come across in our clinical practice will be within the boundaries. But in case there is a case which is out of bounds, and for most formulae, it's again going to be out of bounds because these extreme eyes are what are challenging. And is my understanding right when I assume that out of bound just means that the 90% chance of landing within my 0.5 diopters is not there? And even in these situations, for the want of anything better, you can go ahead and use your formula?
Yes. So again, it's just for predictive value, but there are a couple of interesting quirks to this calculation method. All calculations methods have little personality differences. And I think, Doug, you were the first one that pointed out to us that even for the axial hyperope, when the patient showed up as an out of bounds calculation, the accuracy was still there. And we're still finding that also. It's an opportunity to have a discussion with the patient, to let them know prior to surgery that there may be a problem. If you tell them before surgery, it's not your fault. If they find out afterwards, you own it, so to speak. So it has a couple of values that way. You get to talk to the patient, and also you might use a different calculation method. So we would go straight to Barrett And quite often, Barrett gives a result that's very similar to RBF3. And then if there was a divergence, we might look to our next trusted formula. But immediately it's a heads up that this is not something normal.
Dr. Koch would like to leave, but before he leaves, I just want a few quick answers from both of you. You know, the regular eye, which formula would you go? For a hypermetropic eye, which formula would you go? For a myopic eye, which formula would you go? Quick answer, quick understanding on that. Because the take-home message for most people who are watching, this is the question.
Still RBF3 and Barrett for all, but in the hyperope, I tend to like the Holiday 2 a little bit better than the Barrett. So for them, the high hyperope, I would go Holiday 2 and RBF3.
And I would echo Doug's observation. So that would be what I would do as well.
And accuracy of measurement, we all agree that it's axial biometry that is there. You know, that's the way to go. And keratometry would be from the IOL calculation that we have from that. Is that right? Is that what that's the main concern that we have?
And you have to look at the spots to see that they're accurate, and you have to check the standard deviations and make sure that, because even the biometers can make big errors if this corneal surface is not good or if the patient didn't blink appropriately.
Right, and I might say that a measurement's only as good as our ability to know what it means. So as Doug points out, following validation criteria is really important. And tell your staff to get out of the habit of just pushing buttons, but think about what it is that they're measuring, and if something's wrong or it doesn't look right, they delete and repeat. And that's the first step towards better measurements.
Putting artificial tears before doing any measurement, it's not supposed to be done. I mean, you said something very interesting. For 15 days you give them and you cleared out the whole thing. The scenario changed because of that, but your consistency of answers became better with that.
Right, just putting in artificial tears moments before keratometry, I don't think it's going to really be the answer. You need to stabilize the ocular surface. Adi Abulafia in Jerusalem did a wonderful little exercise where he took normal volunteers, did keratometry, and then 1 or 2 days later repeated the keratometry, and it was different. And optimizing the ocular surface helps to remove that variation.
On the same note, if I was to ask a very stupid question, you do refractive calculation for a person, including you, this morning, this evening, and maybe tomorrow and day after. It's bound to be a quarter number, half number here or there. You know, the same two individuals without any subjective changes. Would that be the real dynamics that we're looking at?
Well, here in the desert where I live, I think the ocular surface plays a role. Go ahead, Dan.
Yeah, great. You said it, Warren. That's right. Cornea, 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 cornea. Get your corneas right. Do exactly what Warren said. We do the same thing. We're not as aggressive with warm compresses, but our patients use artificial tears 4 times a day for the week before they come in, or we ask them to. And it's the cornea. That's our message. The cornea and the new formulas.
There you go.
So corneas, ELP, and the new formula to constitute.
Right. I had a quick question, Himanshu, if you'll allow me, because we have 2 of the masters of biometry. I have had a couple of patients recently who are post-RK followed by myopic LASIK as well. And, they've been so flat that none of the devices are ready to measure the cornea. And, it's been like the Pentacam shows up something with, the EKR65 showing up like 24, 25, and some of the devices showing like 28. And, it's been crazy because what to trust and what not. So what would you suggest for measuring the cornea for eyes which are so flat that, most devices won't measure them? And how would you probably approach them?
Well, I'll make one comment before we go on here, that here in the state of Arizona, we're like one of the radial keratotomy capitals of the world. And the LASIK that they had afterwards was most likely hyperopic LASIK rather than myopic LASIK. And there really is no good answer. I mean, you're way outside the algorithms of all the calculation methods, which usually use some sort of regression-derived method to come up with a correction for the cornea. The only good news is hyperopic LASIK and radial keratotomy change the Gould-Strand ratio in the same way. It's a little paradoxical that one is an incisional myopic procedure, the other is ablative hyperopic, but they both increase the Gould-Strand ratio. So you can ignore the LASIK and go with the majority change, which was due to the radial keratotomy.
Yeah, I completely agree. And those patients, informed consent's everything. I tell that patient you've got probably a 1 to 5 and 1 in 10 chance of needing an IOL exchange. It's just going to be that inaccurate, and prepare them for a second procedure. And if you, by some reason, get it right, you're a hero. And otherwise, you've just met that very low expectation.
Dr. Bhavika,
I need to depart, everyone. I have another obligation. Thank you so much. I've enjoyed the conversation and the other talks very much. I wish you all a good evening.
Thank you so much for getting your valuable time before your outpatient department starts, Dr. Koch, and very, very sweet of you to spend this morning with us and give us some valuable information today. Thanks once again, and we ever so grateful to you being always there with a smiling face. We only missed your bow tie, this morning.
Yeah, no. Thanks.
Thank you. Have a wonderful day and a great weekend.
Dr. Bhavika, in this situation, which Dr. Gaurav was asking, would you like to add something?
What I would do, perhaps, I don't know, it's open to discussion, that I would I will leave the patient aphakic after 3 or 4 days. When the corneal wound edema settles, I would do aphakic refraction and calculate the IOL power by Vergen's formula and implant that IOL after 8 days.
And if we're talking about a situation after radial keratotomy, remember that these patients are initially hyperopic. And so you need to wait 6 to 8 weeks before you make a decision regarding the exchange. And we use what we call the rule of twos. And that's 2 stable refractions on 2 consecutive visits, at least 2 months after surgery, because these corneas do take a while to stabilize after radial keratotomy, if that's what you're referring to.
Yes, sir. And anyway, doing IOL exchange after 6 to 8 weeks is rather tough. So leaving the patient aphakic, waiting for the corneal edema to settle, and then doing aphakic refraction, and by Vergen's formula, calculating the IOL power and implanting the IOL, that will be a bit easier.
No, that's an excellent way to do it. And what I might also recommend is that if you have the luxury of doing the exchange calculation in a stable pseudophakic eye, following radial keratotomy, I would not target plano. I would target -0.5 to -0.75 because of hyperopic drift. The old joke is that radial keratotomy is the gift that keeps on giving. And many of these people will continue to drift towards consecutive hyperopia over time. So you want to keep them a little bit minus with that in mind. That way they'll always be changing towards something better than away from what it is they want.
Excellent. I had one question for you. What about artificial intelligence for toric calculations?
Well, it turns out that we do have that. I think Dr. Luthra had mentioned about the Abulafia-Koch algorithm for toric IOLs, and that's actually combined with the Hill RBF3 method. So if you're using a Lenstar and you use Abulafia-Koch, the spherical component of that is calculated by artificial intelligence, and then the toricity component is calculated by the algorithm developed by Doug Koch and Adi Abulafia, and it's very accurate. It does a very nice job, as Dr. Luthra had mentioned.
Thank you.
In fact, Warren, I wanted to tell you that we did a study recently with out-of-bounds eyes and trying to see whether those eyes ended up getting a refractive surprise if we still continue to use the Barrett's calculator for Barrett's Universal 2. And you'll be surprised that we found that while Hill RBF would label them as out-of-bounds, and we went with the implantation, we found that we still had the Hill RBF perform
Better than
predictor, even recommended not to use it, than what the Barrett's was saying. And we're publishing that. It's in publication now, where we've done a comparison of about 100 eyes of out-of-bounds eyes from the Hill RBF2. And let's see, I'll try to study them on the machine and see if that makes a difference.
Yeah, and I think what you'll find is that if you run the same eyes through RBF3, you'll find that they won't be out of bounds indications at all. For an eye, unless it's very, very unusual, it's highly unlikely to get an out of bounds calculation now. So that's the main advantage of this updated method. And as I mentioned, we spent between 10 and 30 hours a week for 2 years developing this. And I think it represents a real major advantage. We're already working on RBF4, by the way. We have some other ideas as to how we can make it better. But it's become almost a full-time job dealing with this. And I also might mention, people like Dr. Luthra and say the people at Aravid down in Tamil Nadu, they're all volunteers. I mean, everything Dr. Luthra has done, he's done out of the goodness of his heart, and including all the other volunteers around the world. And this is a true worldwide collaborative effort with everybody just working for the benefit of ophthalmology. And it's really nice to see people working together like this with nothing in return except better results. And I think we all benefit from the kindness and generosity of people like Dr. Luthra.
Thanks for those kind words. Sir, since we are in a big forum today, and I have I'm sorry if I'm, pestering everybody too much, but the thing that we just spoke about half an hour back about the final outcomes, the refraction, a correct refraction being the limiting factor, we found the same problem that when we look at big databases, for example, if we look at like 500 eyes or say 1,000 eyes, and we are trying to make sense out of them, we realize that we have maybe 4 different people doing those refractions. We have never been able to find one person or one single person doing the refraction. So when we do big studies, Warren, how do we find that, how do we trust that data? Because, it's not possible that when you have a few hundred eyes, that all the refractions would have been done by the same person and they will be as accurate. So how do you kind of take away the bias? And what's the best way? Is there an objective way of doing the measurements post-operatively to see outcomes and analysis, which is the best objective way if there is one?
Well, and imagine if you have 35,000 cases that you're looking at and you're going to be basing an artificial intelligence algorithm on refractions that some of them may be by autorefractors or poorly trained technicians, some by the doctors. Not everybody's going to do a careful endpoint refraction like with the red-green duochrome balance. So what we've done is we've developed a method for statistical filtration where we look for improbable outcomes or eyes with very similar axial lengths, Ks, anterior chamber depths, but widely variable refractions. And we figured out a way to identify outliers and improbable outcomes and exclude those from the database. And that took a lot of time. Again, it took a full-time PhD mathematician to come up with engineering-based statistical methods to do these filtrations. For an individual surgeon working in a clinic, you just have to have standards for refractions. We use a duochrome endpoint, or the most simple thing that you can tell your technicians is they start out hyperopic, and if they know what they think the spherical equivalent should be, it's blurry, one click, blurry but better, sharper and darker, then about the same or perhaps not quite as good. And that's probably as accurate as you're going to get it. But I agree that refraction is really one of the limiting steps in this whole process.
So I think that when you're talking about multiple centers and so many thousands of eyes, does the platform that you use to feed in all this data also matters? So something like Veracity, which uses, which could integrate all this information, because the quality of the data that you deal with is extremely important. This AI-based formula, would it make a difference?
Well, actually, I was the original technical director of Veracity, so I'm very familiar with that. The problem with Veracity is that it may just look at the most recent refraction. So there's no good filter in Veracity. What we've been doing is we've been having physicians do manual entries into Excel spreadsheets, and that's given us the most reliable data collection. And then we look at the data very carefully and do statistical filtration to look for improbable outcomes, obvious outliers, IOL power error for axial length. We've seen pretty much every type of variation you can imagine. And again, a measurement's only as good as our ability to know what it means. And when we collect data from multiple sources, we're always going to have these questions. So if you can identify outliers, then that's a place to start. And then you can refine that process using sophisticated mathematical methods.
I think we should, I think we have to thank Warren for taking out time and being here, because it has helped all the viewers to solve their queries. The bar has to be raised. And when we are raising the bar, it's not going to be very simple, because from 92 to 100, it's going to take a lot of time. But for each one of us around, whenever we have a surprise, surprise should mean not one or more. We have to have a mindset wherein the surprise should be more than plus zero point 0.5 to minus zero point 0.5. If it is more than that, we have to introspect. And when we introspect, we have to go all out to find a solution to this. And for this, I think it has to be an effort wherein your staff members have to be involved. The cornea has not to be ignored by any means by each, as Warren has fully and Koch has said that it has not to be ignored. The cornea, the meibomian gland dysfunction has to be taken into consideration before we really go ahead with it. We have to, thank J&J also for that, because whenever we have, whenever we ask them at any point of time, they've always come up. And I would like to thank Jaspinder for that, and Dr. Himanshu Mehta for coming up with a brilliant idea for organizing such webinars, which would go a long way across the world to elevate and to help us to achieve what we really want to achieve. I would be falling short if I would not be thanking Dr. Vavikar for taking out time, and Dr. Tityal for being there right across, Dr. Ramamurthy for being there, and thank you again, Dr. Himanshu. Would you like to wind off by saying anything else?
Thank you. Thank you so much, Rohit. Thank you very much. First, I would like to thank Rohit. He's been kind enough to thank everyone, but he's been the backbone for every organization part. He's taken a strong lead support. He's been there, totally there for everything, getting J&J, getting all the mails going, and the homework. But Dr. Warren, let me tell you something. You and Dr. Koch, he's not there right now, but there's a lot of excitement which was generated across the country, and all the IIRSI members, huge amount of concentration. And this will go a long way in the history for us to find out and get to the bottom of solving this 2020 problem in this year. And it will help us in the long run to see how we can get you more data, and how we can work on this as universal surgeons across the world to see that we conquer and we come across to see that we get the best results for our patient. That last 8%, we have to work very hard for the next few years. Thanks so much, everybody, for being there and sparing your valuable time. It's been a great time. Dr. Tityal, thanks so much. Ramu, thanks. And Vavikar, Dr. Gaurav, Luthra, of course, always all backbone support. Thanks very much, everybody. And
Thank you.
once again, Dr. Hill, thanks very much. Have a wonderful weekend.
It's my great pleasure.
Thanks, Warren. It was great catching up again.
Likewise. See you soon.
Bye for now.